As I indicated, I'm Richard Swanson. I'm a rheumatologist, so I've been dealing with pain all my professional career. And I learned very early that many physicians and the general public have no idea what the difference between acute pain and chronic pain is. They think, well, it's just pain that lasts longer. Unfortunately, that's not correct. But we don't, and how we treat chronic pain is really quite different than just to, here, take this pill. And the problem has been that we've had so many people getting hooked on narcotics that really shouldn't have been, and who weren't really getting any pain relief. Amazing, these pain pills weren't helping. So we brought in an expert, and Jim and I have known each other for a number of years. Jim is a physical therapist. He's been in practice 30 some years. He has worked mainly in the last 20 years, he said, with chronic pain. So he's really interested in helping patients who have chronic pain. And we'll hear Jim tell you exactly what it is in a few seconds. But I think you're going to learn a lot. This is, Jim says, his third presentation to HASP. And the last time I had him here, he talked about what chronic pain is. Now he's going to talk to you about the toolbox. That's what I asked Jim to talk about. How do you manage chronic pain? What are the opportunities for your pain, for your care, and how to deal with it? You have some handouts in front of you that Jim has prepared on methods that can help you. So you may want to review those. But anyway, I'm going to turn it over to Jim and let him go ahead. Thank you, sir.
Thank you, Richard. So first of all, thank you very much for having me and inviting me and spending the time listening to this me waffle on about pain. I am reasonably obsessed with this topic. Every single day I'm reading one or two things about it. And of course, if you're on social media and you look about pain, you get all of these various miracle cures that come up as well. All of these which are purely BS kind of stuff. Pain is something that is so topical in our age group, but frankly in others as well, that people have, they fall prey to all kinds of things. If you can buy it, if somebody thinks they can sell it to you, they're going to try to. Sometimes they occasionally work, but that's only because of what I would call a placebo effect most of the time, which we'll talk, perhaps we'll talk about a little later. So I do, since it's been a while since I talked about the difference between chronic and acute pain, I will cover that briefly as we do this. So first question though, how many of you have chronic pain? Raise your hands. Yeah, pretty much, right? How many of you believe that your chronic pain is because you have, well, we call them issues in the tissues? All right. Yeah, that is the predominant narrative. That's what everybody thinks. And if you still have pain, means something hasn't healed properly. That's sort of the narrative that's there. It is not true. If you get cut and you heal up, your body can heal again, right? You're healing just fine. But if you go into a physician's office, and frankly, most physicians, I have sympathy for the physicians. How much time are they allowed to spend with you? Very, very brief. What are they trained in? They have less training. Like they have something in the neighborhood of 20% of the training about pain that veterinarians do. Okay. And the general physician, what they're trained in is medications. They are basically drug dealers. Okay. When in South Haven, where I work at Bronson, South Haven, I work mostly in a swimming pool. But at Bronson, South Haven, before it was Bronson, actually, when it was just South Haven, they had a group of physicians that wanted to get together to talk about pain management. And I said, I got to get in on this meeting. They didn't invite me. I said, I'm going. This is about 10 years ago. And they said, well, yeah, that makes some sense. So they talk about all this stuff, and everything they were talking about was limiting the use of opioids. That was all they cared about. And I said, okay, well, that's fine, but where's the education piece? Well, see, we all educate. I said, yes, but you suck at it. That's a direct quote. I told that to the doctors because you're in a room with somebody who is desperate for some help and you don't have time to listen to them. And then you're going to tell them you're going to cut them off on the drugs. That's not going to be a situation where people are going to be willing to listen very much to you. Send them to us in physical therapy because what do we get? Right now, I get 45 minutes every day with every patient I see. I get to know who that person is. I get to know what's important to them, and I get to know how we can make some interventions. Now, the misnomer of the talk today is I'm not talking about managing pain at all. I'm talking about managing your life. And your pain often gets better when you manage your life well. So what is pain? What is chronic pain? And what does pain mean is what we're going to get into in a second. But acute pain is very clear. You have an injury, there's a discrete time when you know something happened. And then there's a normal range of healing for different tissues. Pretty much every tissue out there will heal within 4 months. Pretty much. Now, the current definition of chronic pain by the International Society for the Study of Pain is, International Association for the Study of Pain, is that pain that lasts longer than 4 months must be chronic, as if somehow it was magically transformed itself. And the reality is it doesn't. I've seen people with what we normally would think of as chronic pain within a week after their injury. You can't really call it chronic. So the terminology is not very clear, but it's pain that does not react specifically to the tissue damage. It reacts to an inflamed neuroimmune system. And that's what it really boils down to. That's where Richard and I have our great conversations because he understands inflammation as a rheumatologist. He manages inflammation. That's his primary way of treating patients, correct? Okay. But anti-inflammatories, COX-1 and COX-2 anti-inflammatories are the common ones. They work pretty well for the kind of acute inflammation you get after an injury. They don't work well for the chronic inflammation that is out there. And they're starting to get new tools, new understandings of how chronic stuff works, and it's going to get better in the near future. Oh, by the way, new information within the last 2 months. A paper was published that indicates, well, I guess I got to give you background. Anybody know what a nociceptor is? Wow, I'm surprised they had anybody, so that's good. So they're in your nerve endings. You've got nerve endings for touch and pressure and heat. Those are the 3 things. But there's some of those nerve endings have called nociceptors. Those are commonly thought of. I was trained 35 years ago to think of those as pain receptors. That's false. All of you have nociceptors going on right now in your butts because you're sitting there and just, it's question. Sometimes we think of it as danger receptors. If it's too much pressure, too much pain, too much pressure, too much heat, they'll be stimulated. The new information is, guess what? There are male and female nociceptors. Women's nociceptors don't work in the same way that men's do, and yet every single medicine that's out there for pain has been studied on male nociceptors. Wonder why there's more women in chronic pain than men. It's astonishing at this day and age that that's the case. So pain is a bodily reaction to a threat. Okay, that's really what it is. And it's localized typically to a certain spot with acute pain. Chronic pain becomes a little more generalized, more parts of the body, and it doesn't match the normal healing process that we would expect. But what really people want to know is, what does pain mean? So I don't often read things off of the script, but I think this one is worthwhile. Pain is often less of a threat to our tissues and more of a threat to our sense of self, our relationships, our ability to think and express ourselves, and our way of relating to the world. I think that's the kind of thing that we need to focus on. As a physical therapist, that's what I want to focus on. Now, This is the way I explain pain to most of my patients. So Kevin Cuccaro is a board certified pain anesthesiologist out in Oregon who stopped treating patients about 8 years ago now. And he told me, along with a whole room of other people, I wasn't one-on-one with this one, that he would rather be financially bankrupt than morally bankrupt, because the pain anesthesiology does not work. It gives you short-term relief of pain. It never treats the long-term stuff. And it treats pain based on the concept that pain must come from the tissues. You got a bulging disc, I'm going to inject something in that near that disc, or I'm going to burn off that nerve, or I'm going to do some of the other stuff. But the reality is, most of the time, the pain doesn't come from there. Some signals might come from that area, but those signals get magnified by the time they get to the spinal cord. And then they go up into the brain, and you'll see a picture of this a little bit later. All these various areas activate that are involved in pain. And you'll see that in a little bit. So anyway, when I talk about this, I like the concept that the sensation is different. That's why it's down at the bottom of the thing. Now, Kevin Cuccaro, when he created this, he realized that pain is similar to fire. And he's out in Oregon, they get a lot of forest fires. Not on the coast, but in the inland areas. They get a lot of burning. And the forest fires always, or any fire will always have heat, fuel, and oxygen. You will not have a fire if you don't have all three. And how do firefighters get rid of fires? They try to dampen the amount of fuel, or they dampen the oxygen, or they cool it down. Okay. Now with pain, you've got not only the sensation issues, but you've also got what you think it might mean. You also got what it feels like to you. Okay. I'm a physical therapist, but I deal 85% of the time with the thinking and the emotion stuff, because that's what it takes to deal with someone who has chronic pain. Okay. But nobody can say, I'm telling you it's all in your head, because I've acknowledged the sensation stuff is different. Right. So I have an arthritic knee. It hurts a lot. When I sit for too long and then stand up, it's hard to get going again. I've got neuropathy in my feet. I don't like to stand very long. That's why I've got a stool back here somewhere. There it is. But I don't feel those things when I'm talking to you. Okay. The sensations are the same, but I'm engaged in my life in something that's really meaningful. Right? That's important to understand how you can manage your pain. Any questions on that so far? Okay. Now, so most people living in pain want to have the capacity to do the stuff that they really want to do. Okay. They want to minimize any adverse risks. So I'm not saying you shouldn't take some medicine for pain sometimes, but you don't want to take things that are adversely risking. Richard and I had a brief talk about acupuncture beforehand. The number needed to treat is a medical term that Richard would be familiar with. It takes at least 8 people to be treated by acupuncture for one of them to get a 50% reduction in symptoms. I'm sorry, that's not true. It was 5. But it's a smaller number than that. They have an adverse effect from the acupuncture. Okay. And then you want some pain reduction. But again, I don't promise pain reduction. I promise that the pain, or I shouldn't say promise, but I'm predicting that the pain is not going to be right in front of you all the time. It's going to be like a passenger in the back of the bus behind you. Might still be there, but it's not dominating everything in your view. So I'm talking about healing, not curing. Curing is aimed at the disease. Healing is aimed at the person. Okay. Can you live a life that is meaningful, that is valuable, that is tolerably comfortable, despite having pain? The answer is yes. Now, I can't promise everybody gets this kind of relief. I don't promise anything. I do promise that what you can do when you do some of the things that we're going to talk about later is begin to have some control over your pain. Now, if pain that is not controlled, not a whole lot different than being tortured. So you want to have some ability to control your pain. You want to know that if it comes up, you've got something reliable you can do to take it down. But I want that to be active, you doing it, not passive, taking a med or just sitting and doing nothing, because there's no life involved in that. Okay, that makes some sense? So what can you do actively to make things feel better? So the keys to success. This is not just me talking. This is interesting because I put these things on a disk drive and then I changed it. I saved it to the disk drive, but this is the old one. So I took some of those out of there. But anyway, Bronnie Thompson is an occupational therapist in New Zealand. She's the first person that I know of who's done a study on what are the characteristics of people who live well despite pain. And I took part of the title of this talk from the title of her paper, Living Well Despite Pain. As a person living with pain, there's three things you need to do, according to the research that she did of people who are successful at living with pain. One of them is to make sense of your pain and to create a healing story. Story is really important. One of the lines that I love is you only see what you look for, and you only look for what you believe exists. That's sales. The guy who said that was a salesman. That's what I do. I don't do psychology as much. I do psychology of salespeople more than anything else. So if you believe that the reason your knee hurts is because you've got arthritis and arthritis is never going to get better, then why would you think it's a good idea to exercise? Right? Why? There's no rational reason why you'd want to stand and walk and do things if you think it's going to make it worse. There's a slide we're going to come to a little bit later called, or that is affectionately called the vomit poster. And that's the full poster over there, because I want after people to come see it. What's vomit poster? Vomit means victim of medical imaging technology. Okay, so let's say, I'm going to pick any one of you. We'll say Bill here. If Bill took a photograph of his face when he was 20 years old and compared it with a photograph of his face now, would he say he has degenerative face disease? Okay, but if they take an X-ray, if they take a picture, MRI or X-ray of your spine or your knees, it doesn't look the same as the standard, which was when you were 20. You know, all the standards are based on 20-year-old men, basically high school or college students. You pay them a little money and they volunteer to have all these studies done on them. That's how desperate you are in college. Anyway, if you were to look at the details of that, you'll find that everybody in this room has had a degenerating disc, probably, but they start showing up at the age of 15. Now, I was told 30 years ago, no, 40 years ago, that my L5 S1 was desiccated. And I called the radiologist, because at that point, we actually had a radiologist on hand in South Haven, unlike now. And I said, well, Dr. Tan, what's that? I mean, that just means it's drying out. That's normal with aging. So yeah, yours looks like you're 80. Okay, I don't have any back pain now. I did then. I can guarantee you my back x-ray wouldn't look any better than it did then. Right? If I had taken that on board, and as I did for a long time, where I felt better, but you know, if it wasn't a little bit tight, I was worried. And if I had a flare up in the pain, I thought, is this the one I won't be able to get over? That was the language that he used that made me a victim of that stuff. He didn't mean it as a negative thing. He thought he was just being honest, or he was being colorful, because again, you know, in my case, I knew some stuff about what he's talking about. Most of you don't know that much. And so they got 10 minutes to explain your stuff and get you out the door. they'll give you a story that's pretty general, easy to understand, but short stories like that are never accurate, are they? They're sort of a quick summary based on the bias that aging is a disease. That's the bias. Things that are called degeneration are normal aging in most people. So to make sense of your pain, to create a healing story, it's hard to do when you are told, well, you've just got arthritis or some other similar kind of thing. Okay. Acceptance is another one. And now Bronnie, the person who bases this on, she hates that word acceptance. She calls it willingness. I think acceptance is important. We'll come back to that in just a second, but a willingness to continue with life despite the pain, choosing, despite pain, I'm going to keep going on. That's not the same as ignoring the pain. That's saying I have to modify my stuff in order to make it work. Now, Brownie, by the way, is a world-renowned expert, one of the best people I know of in the world when it talks to how to help people manage their pain. And one of the reasons she is not only academically gifted, she also has fibromyalgia. She lives it as well as teaching it. So it's not to say that, hey, you are a physical therapist or occupational therapist, you shouldn't have any pain. That's not true. We're human. We all get this stuff. The last thing in her stuff, and what should have been on the slide if I hadn't somehow screwed up with my thumb drive here, is to be flexible and keep going. Okay? Because what happens when something else will trigger another pain response, you've got to adjust, you got to modify. It's like you're trying to create a map of a new territory. The old map that you had of Holland, Michigan, it's like, well, sorry, you've been transported now to Grand Junction, Colorado. But it's hard to give up your map, but the map doesn't apply to the terrain anymore. You've got to create a new map. You got to explore. You've got to keep trying things. You've got to be persistent. Now, the last three are not in her paper, but I think are really important. Be social. One of the things that, am I moving around too much for you back there? Okay. So be social. That's one of the things that pain robs you of. I don't want to go out and be with my friends because I hurt. I don't want to spend time with my family because they're tired of me complaining about my pain. You know, people who have pain hide and mask their pain a lot. As primates, as mammals, we get an advantage when we have acute pain and we tell people about it because they come help us. But that advantage kind of goes away when it's chronic pain and people get tired of it. One of my favorite lines is, you know, the pain is always new to me, but it gets old for those I'm talking to. You got to keep moving. Got to keep moving. Stiffness. How many of you feel stiff? Okay. That is not a physical property. That is a property of inflammation. You can move and it gets better. That's a reminder. You got to get up and move a little bit. Okay. And laugh and love. Those things are really important. Now, to go through some of those points one at a time. Matthew Sanford is a gentleman who I have huge admiration for. He's a T6 paraplegic, and he's the one that started using the phrase healing story. And he talked about your healing story as something that moves you into a new direction, as opposed to a pretty negative healing story of, oh, I'm just all worn out. I can't do anything. That's not really a healing story. It is a story about what's going on, but it's not going to move you in a direction you want to go. That's a pity me story. Okay. A healing story is, hey, I've got loved ones. I've got opportunities to do things. I've got meaningful things to do in my life still. As long as you have those kinds of things, you can move forward. So to create a healing story, that story, it can change depending on the situation. But you need to focus on creating a healing story. Now, this is my thing about acceptance. Okay. Some people waste a lot of time when it rains complaining about the rain. Other people say, yep, it's raining. Now what can I do? There are some things you might like to do in the rain. I mean, nothing is better than taking a nap on the front on a sheltered porch during the rain. I love that, right? Sometimes I need to stay inside. I wouldn't do it if it was nice outside, but sometimes I need to stay inside to get my bills paid and some other stuff that, okay, well, there's an opportunity here. But with pain, what can you do that is, okay, well, I guess I have to readjust my priorities. I have to readjust my activities, my plans for the day. So Bronnie, who I mentioned before, you know, she travels all over the world. Traveling is hard for her, so she plans. Give herself a day of rest before and a day of rest on the other end before she does anything. She knows that she has to adapt because of her fibromyalgia. That was my outline. You weren't supposed to see that. That was gone in the other one. Okay, so global strategies. I think about strategies way more than exercise. If you go to most physical therapists, I'm going to tell you, do this exercise, this exercise, this exercise. I think that's a bad concept. I think it's a strategy because in my clinic, I see my patients on a good week, if they show up both times, for an hour and a half a week. That gives them 166 and a half hours on their own. If I don't give them something to do that they can do in that period of time, I'm wasting everybody's time. Okay. I can't fix people. Never been able to. With a couple of weird exceptions, but I won't go into those. Those are not about pain. BPPV is a wonderful thing. You feel like a hero as a physical therapist when you do the Epley maneuver. Suddenly they're all better. But by and large, it's the global strategy. So what's the global perspective we're looking at? We're looking at the neuroimmune system. What could we do to get that balance of the neuroimmune system back to a level that's better? We'll talk about that. So the neuroimmune system, I'm going to use the analogy of a teeter-totter, seesaw. Okay, so have you all heard of the fight or flight response? How many of you heard of the rest and digest response? Okay, good. So fight or flight, technically in scientific terms or medical terms, is a sympathetic reaction of the autonomic nervous system. It is the system that gets you ready for a challenge. So you can either run away from the challenge or fight for the challenge or that kind of stuff. But it is mirrored on the other side by what should be the rest and digest response. So if in a normal neuroimmune system, it kind of goes back and forth depending on the situation. But for people living in chronic pain, the fight or flight response is up all the time. And guess what? I say to people I do not know at all, don't know from anybody, Adam or Eve, I bet you don't sleep well. Well, yeah, of course I don't. I bet you got stomach issue too. Oh yeah, I do. They go together. If the rest and digest response is inhibited and depressed, then you can't rest. You're fidgety all the time. You can't settle down. Okay. So the strategies that we're talking about are trying to balance that back out a little bit. Okay, this is where it starts getting practical. Okay. All right. First one is breathing. The beauty of this one is you are all breathing right now. It's available to you anywhere, anytime you're conscious. You can use breathing as a tool to change that balance a little bit. So the first one that I really like, well, actually, it's not the first one. I'm going to do diaphragmatic breathing now. It's a little harder. Now I have 5 tape measures here today, so hopefully you can all have a chance to practice if you'd like. But the easiest way I know of to describe how to do diaphragmatic breathing is not to lay down and put your hand on your belly. I hate that one because I've seen too many people go, that's not really working very well. But if you wrap this around on your lower ribs, sorry, got to get this unrolled properly. Okay, I'm going to wrap that around. Pass those around. Now, if I wrap that around my lower ribs and I take a deep breath, what should happen? It expands. What happens if you're doing a stress breathing response? It shrinks. Or at minimum, it doesn't expand. But I've had people lose an inch when they're trying to inhale. That's clearly a stress response. So if you can practice with a tape measure or just a piece of, doesn't matter what it is, just a string would work, but you should feel it expand when you inhale and relax and contract when you exhale. Okay, that's diaphragmatic breathing. Now, the reason that's important is because breathing through your diaphragm is actually calming. And not everybody does that. It's stunning to think how few people breathe through the diaphragm. I was one of them until about, I don't know, 15 years ago or so. I'm sorry, I move it again. So when you're working on breathing through your diaphragm, it's kind of a slow expansion, and you can learn pretty quickly one of the things that's in your handouts, which is breathing into pain. So if you can, if you have a little bit of tension on the left side of your hand, pushing down, and this muscle's tight, when you breathe, you can expand into the right side. You can expand into your low back. You can expand into your upper back and chest. You can expand into the pain, and that will be a way of relaxing that pain. Okay. You're looking really interested in this. Okay. Yeah. Okay. So the picture of the diaphragm, whoops, wrong one. I thought I'd have a pointer here, but I don't see a pointer. Anyway, the picture of the diaphragm shows how big that muscle is. It's huge compared to what most people imagine it to be, right? And when it drops down, when that diaphragm drops down, when it contracts, I should say, it starts from here and it pulls up and it drops the whole thing down. I didn't bring any more with me, but they were available through the HASP group. Okay. So as the diaphragm drops down, it creates a vacuum in the space above, which is why air goes in and that expands. But when it goes down, it's pushing on all the other organs, which is why that expands. Okay. So the breathing should be expansion, not elevation. Now, if you're running really hard to get away from that tiger or from, well, not Richard, he's too slow. But if you're trying to get away from some of these people, then you might have expansion here and elevation. That's what all the athletes do when they're running in the Olympics. You'll see here shortly. It's coming up, but it's also going out. It's not primarily this. These are called accessory muscles for breathing. The primary is the diaphragm. Okay. In American culture, Western culture in general, but American culture in particular, we stop breathing primarily through our diaphragm about the time we hit puberty. Now, what I'm saying now is absolutely not scientific fact, not proven, it's my own opinion, but we live in such a sexualized culture that everybody thinks, you know, you don't know a 10-year-old anywhere that cares much about their body. You don't know a 15-year-old anywhere who doesn't. What we're all told is big chests and flat bellies. And we learn to breathe that way. Now, maybe not everybody, but all the people I see do that. That may be one of the reasons they have the pain in the first place. Now, the picture on the right side shows what happens in that abdominal cavity. When the diaphragm goes down, the pelvic floor diaphragm goes down too. And it comes back up. And if you sit with your breathing for a while, you can feel that happening. And having the ability to feel that internal awareness is quite calming. So sitting with your breathing is by and large a really good thing to do. Now, in addition to that, there's a technique I call straw breathing. So a McDonald's straw is a good size straw. if you were to blow out through that straw and then inhale through your nose, and I use my hands to describe this. So I'm going to inhale through my nose. That's all I need to do, just a quick sniff. And then I'm breathing out now because I'm talking, but I could still go. I got enough air with that to do all of that as well as the talking. It's like half a second in, 10 seconds out, something like that. Now, fight or flight response again, rest and digest response again. Guess what? Every single inhalation is associated with stress. What do you do when you startled or scared? What's the first thing everyone does? Okay. Not only do you suck air in, but you also tighten up these muscles in neck and shoulders. Your neck is the most vulnerable part of your spine. And so you protect it with this. That's instinctive. What do you do when you know everything is okay? Okay. Every time you inhale, the fight or flight response goes up. And every time you exhale, the rest and digest response goes up. But if you make that exhaling longer by the quick inhale and the long, slow exhale, you begin to balance things out. I've seen blood pressure drop by 30 points with 3 minutes of breathing this way. Now, that's not normal breathing, right? It's an exercise to help you get back into control a little bit. So practice that right now. You try to follow my hand. I'll try not to go out as long as I normally do, but the sniff on the inhale. Feels kind of good. Right? Brings everything down, tones everything down. That changes your physiology. That physiology is involved in the nervous system and the immune system. Inflammation should get better with that. Frankly, I don't know of any studies that shows that it does, but it certainly feels like it does. The addition of inflammation or the immune system into this whole conversation is fairly new. And most of the research has all been done on what happens at the nervous system. It is presumed that some of this happens with the immune system. Now, next thing that is really common is a boom or bust response. Now, those of you who live with chronic pain, you know the boom or bust response, I'm almost certain, because almost everybody does it, which is you do a lot and then you hurt a lot and then you don't do anything and you'll rest and give it some time and finally you feel better. And then you got to do a lot because you didn't do anything for a while. And then the whole cycle starts over again, right? And you generally get weaker and weaker over time if you keep doing this and your pain doesn't improve. So a pacing response, a pacing strategy, I guess is a better way of saying it, is to say that, all right, let's say I'm going to vacuum my living room. I'd like to vacuum the bedroom too, but if I do that, I'm going to hurt too much. So if you vacuum maybe half of the living room, you go get some coffee, you sit for a few minutes, you finish that, you go get some, go to the bathroom, you do something else, and then you go. If you stop before it gets painful, by the end of the day, you got a whole lot more done and you can sleep better because you're not in so much pain. So a pacing response or pacing strategy of taking the breaks before you need to is a useful strategy. Does that make sense? Right? It's not instinctive. Almost all of you are pushers. Got to get the job done. Because if I don't get it done now, I can't get back up again. Well, that's because you waited too long to take the break. Okay, now one of the other handouts in there is progressive muscle relaxation. I'm not sure who Jacobson is, but these are called Jacobson's exercises. My brothers learned these in college in the 60s, so they've been around a long time. But basically, one of the things that I think underlies all pain is tension. Okay, your back feels tight all the time. Your neck feels tight all the time. Even when your pain scale, it might be 1 or 2 or 0, you're still tight. And you still think, oh, something's going to happen one of these days. You can't really relax, right? Some people are so tight that they don't know what it feels like to relax. And so these exercises are all about tightening and then relaxing at various parts of your body. Some of them talk about starting with the face, and some of them start talking with the feet. But either way, you move your way through the body, you tighten up the muscles, and then you focus on the relaxation afterward to learn what it feels like to relax. Now, that straw breathing that I just mentioned, that we just practiced, and this Jacobson's muscle relaxation, those are 2 things that are great to do before you go to bed if you're having a hard time sleeping. Get you so you can really relax. Okay. So I don't want to go through all of this stuff. It's a little awkward to do in sitting in a class, and it would take, yes,
We have a question online about the straw breathing.
yes.
What if I am a mouth breather? Does the breathing exercise still work?
Short answer is not as well, but if you're a mouth breather, shut your mouth and breathe through your nose, and it will open up. It will loosen up. It's hard to get yourself to do that because it feels like you're going to struggle with it. But typically within a minute or 2, things are going to start to get better. You'll struggle with the breath. So the first thing is to get the nose clear enough so that you can do that. There is a normal cycle that our noses go through anyway, where one sinus is more closed up than the other one, and about 20 minutes later it switches to the other side. That's normal for everybody. But if you breathe through your mouth, your nose will become more congested. If you breathe through your, I spent probably 5 years doing the 3 times a day nose spray that they say you should never do more than 3 days in a row. I did it for 5 years. My doctor was horrified when he found that out. I was a mouth breather. And when I stopped doing that, I struggled for a while, but as soon as I concentrated on breathing through find out which one of those sinuses or nostrils was a little bit more open, and I'd focus on that one. And you can actually learn to, if you really pay attention, I can open up my sinuses consciously. I can feel inside. Okay, some of that you can do. It takes that internal awareness. So if she can't do it with the mouth, get started, or if she can't breathe through the nose, get started with the other one, but also practice doing it through her nose. Try and see if she can open that up. Because mouth breathing is also associated with stress. There are nerve endings in your sinus cavities that go directly to the emotional part of your brain that say you're safe, because you can't breathe through your nose unless you're safe. If you're under stress, you can't do it, because we always want to get more air in. So it's all part of a whole pattern. Ask her if that answered her question adequately. If it doesn't, ask again. Okay, diet. Now, if you look at me, you know I need to work on my diet. One of the things I will tell you for sure, I stopped at McDonald's on South Washington one year about 5 years ago, and I don't know why. I was just really, I'd already had a cookie somewhere else, and I stopped and I got a milkshake, and immediately my feet were burning. All right, I know for sure that sugar is a stimulant, neurotoxin, essentially. For my neuropathy, sugar is bad. It's hard to get rid of, but it is not an easy thing to do. So I didn't put anything in specifically in the handouts on this, but if you look down at the bottom, basically the easiest way is to say it is try to shoot more for a Mediterranean type diet. Every day, lots of veggies, lots of fruits, carbs with a low glycemic index. You can look up glycemic index. They think you should have yogurt every day. This was a study done on chronic pain patients and to see what diet would do for them. Now, it's not a great study, and they would admit that it's not a long-term study saying if you do this, this will happen. What it is a compilation of all the various things that have been studied individually and they put together. And if you want that study, send me a message. I'm sure the HAS people can get one to me. My Facebook page is the easiest way to, for a pain. You can find me on Facebook. But diet has everything to do with the fight or flight response and the rest and digest response, doesn't it? Right? How many of you heard of the vagus nerve? Okay, vagus nerve. It's kind of a big thing that a lot of people talk about vagus nerve now. 80% of all the fibers of the vagus nerve go from your gut to your brain, not the other way around. What you eat talks to your brain. The signals that you get from your gut, a lot of them are stimulated by the bacteria and viruses and other things that live down there. When my gut microbiome doesn't get enough sugar, it's telling me I need some sugar. I try to think of eating more to feed that microbiome than to feed myself. It's not an easy transition to make, but that's what I'm trying to work on. So diet is really a critical kind of component here. Now, yes. Quite frankly, I can't remember. Oh, her question was at the top of that pyramid was some supplements. There's vitamin D, vitamin B12, fiber as a supplement, sensing. That means you're really having a hard time doing stuff. But N3, I can't remember right now what that was. Yes.
It's the fatty acids.
Ah, thank you.
N3 versus
Okay. So what Richard just said was N3 is a type of fatty acid, and that it's comes in food and is better to be absorbed. But if you're talking about it as a supplement there, they're implying that some people don't get enough in their regular diet, and at least until you can change your diet, try to get some of the supplements. Now, if you notice up at the top, that's like minimal stuff. You really want what's on the base of the pyramid. If you get that right, you don't need the stuff at the top very often. Thank you, Richard. All right. I mentioned, or I alluded to this earlier. So the prefrontal cortex is number one in the front part of that diagram. That prefrontal cortex deals with thinking and pain and planning and empathy and emotional balance. Okay. The more energy that is using to deal with your pain pattern, and by the way, every one of these 9 is active every time you have pain. And that's true whether it's emotional pain or physical pain, doesn't really make much difference. Those are all active as part of the pain pattern, shall we say. And one of the strategies is, all right, if I want to rob that area of some of its ability to participate in the pain, I want to do some of the other things that that area does. Did I send that one through as one of the handouts? I don't think I did. I can send that through if anybody wants it later. But you've got to let me know which ones, how to get hold of it. At any rate, so that's where the prefrontal cortex is where the nerve endings from the sinuses go that tell you you're safe, as it goes right to the prefrontal cortex. Okay, let's go to number 3 down in the brainstem. Okay, that's the amygdala. Fear and emotional extremes. Okay, sight and scent, PTSD. Those are that area is really active with fear. Okay. Now, one of the things I haven't mentioned is that a significant percentage, more than half of all people in chronic pain have had trauma as a child. Okay. When your nervous system and immune system are developing in formative stages and you do not feel safe, it will develop in such a way to protect you. You're going to be really good at reading the room and seeing if there's somebody that doesn't seem safe. You're going to be aware of that way before other people would. When I talk to patients about this, I say, you know this because you know that if I come up behind you and clap my hands and you don't know I'm there, you're going to jump higher than most people you know. Right? Your startle response is on high alert. That will predispose you to all kinds of problems in adulthood, including chronic pain. As a therapist, I don't deal with trauma. I'm not trying to fix trauma. But I can point out that that is something that can be worked on, and your pain will likely improve if you spend some time addressing that stuff. One person I just discharged was first time I met her, but first time I evaluated her, they said something about anxiety. She said, well, I get pretty anxious when I see somebody holding a knife. I said, that's interesting. Later on, she told me that her mom used to chase her around with a butcher knife. Okay. I did that straw breathing with somebody to try to get her to slow her breathing down, and that triggered her because her parents used to lock her in a chest. Yes. Wait for the microphone. Thank you.
I'm very concerned for our grandchildren and all the children in schools doing the active shooter drills.
Mhm.
Because our 8-year-old who is going into 3rd grade, she was just visiting us a week or two ago, and everywhere we went, she kept saying, am I going to be safe here? Pinky swear. And I can't imagine that all the other children that are going through this trauma as well because of these active shooter drills. So long-term, it's not a direct threat to them, but, it's in their face all the time, and it's very concerning.
You are, in my mind, 100% correct. That is really creating trauma. On the other hand, they're attempting to save them from a different kind of a trauma. I'm not sure how to balance those things out. In my world, my thoughts are to people with lose their children to do opioid overdoses, because not only are the kids traumatized by a parent who's non-functional, then they lose them and go into a foster situation. That's a double trauma. And the rates of that is going up. So there will be way more trauma in kids in the future. And not a traumatic note, but social media is raising rates of anxiety, and that's pretty well documented now. And so when anxiety goes up, your risk of chronic pain as an adult go up. And of course, it goes down to the most basic level. Infants, in my professional lifetime, they had just begun to recognize that infants can feel pain. They didn't seem to, circumcisions. Yes, cut it off. They don't feel any pain. I don't know why they're crying, but the logic just it eludes my ability to comprehend. But a woman that I met, who's a pediatric pain specialist, one of her studies was talking about kids, and a lot of kids will get belly Rubin tests and they get a poke in the heel or something like that, right? And they have found that a pain response occurs after each poke in the heel if they got no topical anesthesia before the first one. If they get topical anesthesia after the first, but not the first one, but all the others, they still get the same pain response. But if they had topical anesthesia first, they didn't have the pain response. All right. So as an infant, that is already triggered in that sense. Same kind of thing with vaccinations and things like that. There's way more vaccinations now than when we were kids. But kids, they don't like those things. And so if you can figure out, there's lots of ways that progressive physicians have figured out how to make those not so painful, and those kids do a lot better. And I think that has a knock-on effect all the way through life. So anyhow, but that leads to this whole idea of neuroplasticity. So the reason that slide is up there is because I want you to understand that your brain, even at our age, is changing all the time. You still can learn new things, can't you? That's why you're in this organization in the first place, right? You're learning new things. Yes. I want to get the microphone to her right behind you there, Richard. Thank you.
I'm just looking at this diagram up here. What is the purpose or what does the F part of the brain do? The F part,
F
way
part?
in the back.
That one right there,
Yes.
that is the cerebellum. And the cerebellum is one of the older parts of the brain that deals mostly with balance and coordination kinds of issues. So that, even if you couldn't think, you might still be able to walk around in balance.
Because when I meditate, I feel that that is stimulated, that part of my brain in the back.
Okay,
Don't know why.
I don't either. Yes, it is. I have I don't want to put too fine a point on this because I'm not trying to be critical, but I'm not sure you can feel what's going on inside your brain. You can feel what's on the outside and it feels like it's the inside. But we don't have nerve endings. It's odd. You don't have sensation inside your brain. You create sensation externally in the brain. So I had somebody I saw yesterday who a year and a half ago was in an auto accident and she broke her femur. And she fell at home in the bathroom on last Saturday. Lots and lots and lots of pain. I basically took my hand and put it on part of where it was, and I just lifted the skin up a little bit. That's all I did, just lifted the skin and held it there for about 3 minutes. That's hard to do when you're when your hand's underwater. It's a little slippery. So I did the best I could with as least pressures I could, because it's really important to be really gentle with this stuff. Just lifting the skin. Now you're pinching a little too hard. I was trying to get a real broad hand to lift the whole kind of a balloon of the skin, right? What happened was the area where she was painful became much, much less painful. Now, how can you explain that if you think it's deep, but it's really not? It's superficial, that the nervous system and the immune system are constantly gauging the internal and external environment, looking for a threat. That's one of the major functions. And if there seems to be a threat, the skin in that area, over
get on
that
your
area,
couch.
it's going to have smooth muscle in
We'll
it.
get on your couch. Come on, you're okay. Go ahead. Go ahead.
Somebody's got a happy dog. No. It's just skin. It's just the skin. And we'll talk about fascia in a minute if you'd like to, but fascia is fascinating because it's so bogus. So, at any rate, the nerve endings in the skin got a little more blood flow when I did that, and her pain went down. Now, I say they got more blood flow. Quite frankly, I don't know why it gets better. There's so many things we don't understand, but that's the theory about what it is. It's repeatable. I can do it over and over again with people. They don't expect it to help. It does help. So I'm not thinking I'm doing a placebo, but it could be. Either way, it works pretty well. You had a question, and get a microphone to here in the back.
I think that I have chronic pain. Migraines is what I mostly deal with, and I'm writing a book on it. But distraction, I mean, grabbing a different area or just a little bit away from where you've got pain seems to help.
Mhm.
It could be like, the TENS units work that way. They distract you from pain.
Yep.
And, they're safe, you
Yeah.
know, they're not causing you to become addicted, and you don't have any side effects when you stop using a distraction. There's so many ways you can use distraction.
Yes, you can.
But that pinching of the skin is a good distraction.
It is a distraction, and singing is one we'll get to at some point. I love singing. We'll talk about that in a second. Richard, you had a question?
No, I want to comment. Distraction is one way, but the brain can handle one impulse at a time, not two. And that's why you're dealing here. The brain is not dealing here.
It could very well be what it is. The people who think that they multitask, no, they just switch from one thing to the other fairly quickly, but only one at a time is all you can really deal with. Now, we say that on a conscious level, I believe that is correct. Unconsciously, though, your brain is dealing with thousands of things at once. All right, so it's never quite as simple as we all want to make it. I'm telling you part of a story. I don't know the whole story. Nobody does. I'm gonna finish up with this, and then I'll see what, I don't know what my next slide is because I can't see my slides in advance anymore. But anyway, the point of all this is that the more action you make one part of the brain that would normally be part of the pain, the more you get it to do something else, the less it has the ability to participate in the pain. So this slide is taken from a handout I have on distractions. Okay. And where is it? Somewhere in here. Can't remember which one it is that deals with logical stuff, but sometimes just counting or doing math problems. A lot of people with chronic pain have brain fog. All right. They can't think, they can't do that. It's because their brain is so busy focusing on the pain. You need to find something else to focus on. And it's hard to do, but with persistence and time, you can get your brain to change somewhat. All right. Contemplative practice. This is one that I like because, again, in the context of what we're doing, these are global strategies trying to change your autonomic and nervous system and your immune system. And I talk about meditation, but you mentioned meditation a little while ago. I talk about meditation a lot. People say, well, I can't meditate. Well, I just pull this thing up and I say, well, these are various things that can do the same kind of thing, that are going to help you gain a little more control over what's going on at that moment. Because what is the whole purpose of meditation? I shouldn't say the whole purpose. There's never a single purpose for anything, but the way I use meditation is mostly to bring myself into the present moment. And all of these things will do that. So meditation is one of them, but there's also visualization, Lectio Divina. Anybody know what Lectio Divina is? If you do, you're probably Catholic. Well, Lectio Divina is, in this case, it's reading scripture in community with other people, trying to say, what does this scripture mean to me? Then you read it again. What does this mean to me? Everybody has their turn on it, and then you get a fuller understanding of what scripture is all about. And I mentioned that one primarily because a lot of people, when they think of this, don't think there's Christian stuff involved here, but we're in kind of a big Christian area, so I had to make sure that it was in there. Yoga is in there, dance is in there. Dance is a wonderful thing to do. Physical activity, it's fun, it's social. Sometimes it's hard to get started with because you're hurt. But if you can gradually build that up, that can be a really good thing to do. So we're talking about global strategies. Working on your sleep. If you don't have good, the biggest question I always ask is, when you wake up in the morning, do you feel refreshed? Okay. If you don't, you might benefit from some sleep coaching to figure out how to do that. Now, I didn't bring handouts. So if you've got something you want to write down, there's an app you can get on your phone called CBT-I Coach. CBTI Coach. That's chronic behavioral therapy for insomnia, That is the gold standard for insomnia. Many people with chronic pain develop their insomnia because of the pain, but more of them have it before they had the pain. Your nervous and immune system heals when you sleep. So sleep is a huge target. So if you don't wake up feeling refreshed, the CBTI Coach is an app that can coach you through this stuff. It is put together by two groups, the Department of Defense and Stanford University. Stanford University is where they do all of they were the first ones to do a lot of this research on childhood trauma. And of course, Department of Defense with PTSD. So it's about PTSD in both cases, but you don't have to have PTSD for this to work. So I mentioned earlier, Jacobson's muscle relaxation, progressive muscle relaxation, and the straw breathing. If you want to get yourself settled in so you can sleep better, do one or both of those things, your brain will calm down. You'll be in a much better place to sleep. A lot of people, I would ask, is it your pain that's keeping up, or is it because your mind you can't turn your mind off? And most people, it's a mixture of both, but usually it's the mind is even worse. Okay. A woman called me. She had my home phone because she was in my church. She was a former patient. She had lateral, can't think right now. It's like MS, but it's only on one side of the body. Lateral, what is it? You can help me, Richard. I can't remember right now. Anyway, this was quite a few years ago. She called me up and said, Jim, I can't sleep. I haven't slept in 6 weeks. I'm so stressed. So what can I do? I said, well, tell you what I want you to do. What is the stupidest song that you know? Now, I knew she lived in senior housing too, with thin walls. So what's the stupidest song you know? She said, I think you can find the words to Disco Duck. So, well, that is a stupid song. That's perfect. I'd never heard of Disco Duck before, but she knew it. So that's good. So I said, I want you to sing Disco Duck over and over again for 15 minutes. Start at the end, go all the way through 15 minutes, and then go to sleep. She did. Next morning, I talked to her. She said, well, I slept for 4 hours. I woke up with my shoulder hurting. I sang Disco Duck again. I slept for another 4.5 hours. Best night of sleep I've had. Okay, so what was it about Disco Duck? She felt silly, happy. Singing is a breathing exercise. Short inhale, long exhale. And she was a little bit nervous about, feeling silly because her neighbors might be able to hear her, so there's a lot of that, but it was that silliness. We have within our own bodies the ability to create all kinds of chemicals like oxytocin and various things that will calm our pain down. Okay. Singing is really good. Okay. A lot of people use prayer. But I've had, one woman, I asked if she prayed, she wanted to bowl. I said, I knew she was a church going woman. I said, so do you pray about that? She said, yes. I said, so good. What's it like? She said, dear God, please help me pray here. Please help me keep bowling. Please, please, please help me. I said, wow, I'm glad you have that kind of relationship with God, but would it feel better if you said, oh God, thank you that I'm still able to, right? Just to say you're praying doesn't necessarily mean you're helping yourself in the way you hope to be helping yourself. So these are all things that help improve sleep. So working on sleep is really useful, and the CBTI Coach is a tool that can help you work with that. Okay, now we've got local stuff. Okay. Now, the breathing into your pain is a local technique, because breathing into your pain, you're focusing on the area that is painful and you're trying to drive your breathing into that area. Now, I've gotten actually to the point that I can breathe into my foot, which is completely illogical, but I can feel sort of that expansion and contraction. I know it's a pareidolia. It's something I'm imagining happening, but it still works. I can get that body part to relax. by doing breathing and focusing on that expansion and contraction. Okay, I believe this is one of your handouts. So you can go through that in some detail, but that presumes that you can do the diaphragmatic breathing first. That's what makes this a local strategy, not a global strategy. Okay. All right, this is the vomit poster. This doesn't really belong in this section. This is one of the ones that I moved around. It was supposed to be somewhere else. But that's a close-up of this over here. But you can look and you can see, let's look at cervical spine. 98% of healthy adults and seniors with no neck pain still had degenerative changes. 98%, no pain. It's normal. A 10-year study compared the MRIs of healthy people with those with whiplash injuries, both immediately and 10 years later. There's similar results. 3 out of 4 having neck bulges, but no pain, and most of them over 10 years, but the whiplash people still had pain. Okay. So when you become a victim of medical imaging technology, a vomit victim, if when they read those reports, they don't put them into context of what's normal. And that is surprisingly rare. I've seen it once in my professional career in my area, one time. And of course, patients aren't told that. They're just, oh, I'm falling apart. This is another one that I didn't want to have in here, but that's all right. It's a good one. So the language that we use, this leads us to a discussion of placebo versus nocebo. So all of you have heard of the word placebo, I suspect. Okay, placebo is a Latin word that means I will please you. So if you're in a hospital situation and you're in a lot of pain and you got an IV in and somebody comes up and they say they're injecting a pain relieving medication into your IV and you can see them inject it, you will get pain relief. But if it's behind you and you don't see them do it, you don't get the pain relief if it's not the real stuff, right? So that's a placebo effect, right? So you can get a saline injection and get pain relief. If you see it happen, you can get a saline injection that you don't see and it doesn't do anything to you. I like the word meaning response better than placebo, but either way, the medical term typically is placebo. Nocebo is the opposite. Nocebo is I will harm you. And they're harming you with language in this case. And so how many of you have degenerative changes? Yeah, they're normal age changes. That's just what it is. Don't worry about it. All right. You got something that's out of place. How many times have I been told my back went out? So where'd it go? Did it have a good time when it was out? I don't know what that means. Disc cannot possibly slip. That's physical impossibility unless you were in an auto accident and are now paralyzed. It does not happen, but that's the language you use. And the language you use informs what you feel like is going on, your sense of threat or danger. And you think about all the various things that people have told you, your back is unstable. That's BS. Bone on bone, right? This gets to Richard's thing. It's not the bone on bone that's the issue. It's in any inflammation you got. I have no disc at L5S1. It's been bone on bone for 30 years. I don't care. It doesn't matter. I know people, colleagues of mine, when they describe some of this stuff to patients, they start to hurt. It happens, right? A rupture. If you have a ruptured ligament, that's a grade 3 sprain. ACL injuries. You know that a significant portion of those will heal without surgery. How many people have a torn rotator cuff in this room? Wrong. Every one of you at your age. Every one of you have a torn rotator cuff. If we were to look over on that poster there, a significant percentage of baseball pitchers actively playing in the sorry. I'm not a baseball fan. They have rotator cuff tears. They're still pitching. They don't have pain. We got to stop pathologizing some of this stuff. That makes you a vomit person. And these kinds of things are languages that make you feel worse. I don't know what's coming up next because I changed these around a little bit. Here's one I like. This is the one I was playing and ending on. Okay, so if you're going to try to recover, so to speak, or come to some healing from your chronic pain, early on, you're using a passive strategy. You got a lot of panic. And some of you might still be there. You're desperate to get some relief. You can't imagine a life with this kind of pain. But the more you feel that, the more you're putting that pain in the front. It's blocking the windshield of your car, so to speak. All right. You grab any quick fix and you spend a lot of money on all these various fixes that come up on social media and your email. Okay. When you get into more of a learning phase, you begin to look for opportunities that you can control some of this situation. How can you continue to move through life? You want to try to build a team. Maybe you've got a health professional on that team. Maybe you don't. Maybe you've got family on that team. Maybe you don't. Sometimes the families are worse. Okay. Families, spouses that are too helpful, don't let you do anything on your own. Spouses that are not helpful enough, you end up divorcing. There's a balance there you've got to find. But you need a team because you can't do it by yourself. If you could do it by yourself, you wouldn't be in this kind of pain. We wouldn't be having this conversation. But, that's what I try to do. I try to be on someone's team and give them some coaching, but they've got to do the exploration. They've got to do the work. I don't fix anybody. I can't. Okay. What are your strengths? We always focus on weaknesses in our society. What can you do well? Now, one of my friends is a therapist in Oregon who she calls it the Titanic model. Titanic, imagine being on the Titanic and you hit the iceberg and the ship sinks. And you, one of the last ones, and you fall overboard as the ship is going down. You are deep underwater. Can you be expected to help yourself when you're deep underwater? Not even close. You're panicky. You're grasping on anything you can. You're struggling mightily. You are completely in a life or death existential crisis. A lot of the patients I see coming in, that's where they're at. Those people I help more than the others who make it out into that learning phase. Okay. So you can't treat everybody the same, but you can get them to move into that where they can start to explain. So it's now they're up at the top of the water and they're grabbing onto things. They're holding on, catching their breath, right? That's sort of that middle area, that learning area. Well, then imagine that they actually build a raft and they get out and they really feel okay. Like they might really make it out of this, but then they can start helping others, right? That's what I really want from today. I want you to get some sense of what's going on and you to be able to share this with your friends who are also living with pain. Say, I tried this and it seemed to help me a lot. Because if you are actively involved in your own care, it's a lot better than if you're relying on going to doctor's appointments and getting frustrated because they only spent 10 minutes with you and they didn't listen and they changed my medication because it's a different doctor because my old doctor moved on. It goes on and on. The frustrations of the American healthcare system. Now, one of the slides that I had in here that I apparently messed up with, I apologize, was about strengthening. When we talk about local strategies, we're looking back a bit here. Exercise was one of them. Okay. Stretching. Should probably stretch some every day. Do your muscles get longer when you stretch? Not a bit. Does your fascia stretch? not a bit. I hope it doesn't stretch. We'll come back to that. Fascia, any of you know what fascia is? You know everything. It's a connective tissue. It holds us together. The idea of stretching fascia is so silly because number one, it's not possible. It takes 1,000 pounds per square inch of force to stretch IT band by 1%. You can't do that. Number two, if it was stretchy, you wouldn't be able to stabilize yourself. You'd be all over the place, right? That's one of the buzzwords. And I got involved in a little social media thing with a group one time. They talked about this technique to stretch fascia, and I said, well, the only way to stretch fascia is with a scalpel. And, oh my goodness, did I get attacked? Right? Well, I did this and this way, and I'm not saying they didn't have results. I'm just saying they didn't do what they said they were doing. Completely different things. The narrative, what you're talking about, is not helpful. But at any rate, you do need to stretch on a regular basis because it feels good. What is the first thing that cats do when they wake up? They stretch. What a lot of people do. We stretch too. But I had a woman yesterday who hadn't stretched her neck, and she's so stiff and so painful, and she had huge pain every time she did this. She didn't recognize, she thought it was all in her shoulder, but you know, the shoulder is one of about 8 joints that participated in that, and most of the other ones didn't move. So we just started doing things with her neck, and pretty soon she's moving her shoulder fine, right? You've got to move. If your body can do it, it probably should do it every day. And then strengthening is another one. How many of you know? You probably do. Sarcopenia. So sarcopenia is the inevitable loss of muscle strength as you get older. We can't do anything about that in terms of the fact that it exists and that it's common. And none of us are as strong now as we were 15 years ago. Unless you're one of those rare people who work really, really hard all the time, but we're in bad shape then. You can sort of gain back up because none of us are anywhere near 100% of our potential strength. But you lose potential strength as you get older. You can't do anything about that. It's just going to happen. But what you can do is focus on keeping that strength as long as possible. So your balance is better. You have fewer falls. Now, I am obsessed with 3 things in my life. My grandchildren, yay me, Kane, yay you, and riding my bicycle. I still can't get up off the floor very well because I don't work on that. Exercise when you're younger is optional. Exercise when you're older is required if you want to maintain your ability to do certain things. And it doesn't transfer over from one exercise to another. You got to do a seemingly well-rounded kind of thing. You need to strengthen your leg muscles. You need to strengthen your back muscles. You need to strengthen your shoulder muscles and neck muscles. You need to work on your balance. Each one of those things separately to have a well-rounded program. What does that have to do with pain? Not a whole lot. It has a lot to do with capacity for life, which is ultimately what I've been talking about. All right. So I think with that, I'm going to end and ask and see if you guys got any questions.
I have a question online.
Very good.
Would it be possible to get a copy of your slides?
Sure. You can post it. You're welcome. Yes. An abundance of microphones.
For those of us who may think about changing our medical doctors, could you tell us the pros and cons between an MD and a DO?
No. No, I can't.
I'm sorry.
Really, the theory of a DO is a certain, that there's a certain theory of what causes diseases. But today's world, today's world, not 20 years ago, but today's world, there really is no difference, not at all.
So
The best rheumatologist at the Cleveland Clinic is a DO. One of the best cardiologists that trained me was a DO, not an MD. Did it make any difference? He taught me exactly the same thing that the MDs did. So in today's world, it really means nothing. It's based upon a basic philosophical theory of the cause of medicine, a cause of pain. Well, it is, but it doesn't change the practicality of what you do. Because many of the DOs will say, that was nice theory, but it's not what we do. It's not how we treat people. Most DOs and MDs treat people exactly the same way. The only difference I found is that some DOs are much more into some of these stretching and exercise programs. It just happens they've been taught that way. Probably better off than MDs. But really, truthfully, I don't find any difference whatsoever. And I think that in the past there was a difference, but not now. There really isn't any now. The DO schools were discriminated against by the MDs. It was a nasty, nasty fight. Today, it really there's no fight at all. You can take a DO and an MD and have them apply to the University of Michigan residency program. They're equally accepted and they're equally well trained. There's no difference.
So
There's good DOs, there's good MDs. It's just a name you put after your initials you put after your name.
I would echo that largely, although I would say that the philosophical difference that was evident when DO started, in terms of the cause of disease, was a little bit more, shall we say, holistic than MDs were. But as Richard said, the practicalities of daily practice means they have just the same limited amount of time and the same resources available to offer you. So functionally, it makes no difference, with rare exceptions. But that's the same with any doctor. It's not so much DO versus MD. It's that some doctors have better understanding of this stuff than others and are willing to buck the system a little bit differently. But I think your chance of finding one that you like is more individual to the doctor than it is to their degree.
Give you an example. I had a surgery on my back. It helped me immensely relieve the chronic pain in my legs. It was a DO. He trained at the University of Michigan. So he got MD trained him. So it made no difference. It's just an initial after his name.
Well, we talked about that one a long time. Is there any other questions? Yes.
No question, just a comment. Unfortunately, and fortunately, I had the opportunity to use physical therapist over the years. I think you guys are miracle workers. It gives you such an appreciation for the human body, how you can recover. I'm all about doing stretches and sort of thing when you can avoid medicine. And I think your discussion today was amazing because you've talked about the mental aspect of healing your illnesses, which generally you don't hear about in a physical therapy conversation. So this was a great topic. Thank you very much.
You're welcome. Thank you.
Thank you, Jim. We appreciate it. You're right. I mean, Susan, when somebody says, well, it's all in your head, you take it in a pejorative fashion. You know, you say they're just writing you off. But in many cases, in real cases, they're telling you that that's where the problems are. And forget the pain in your leg. Let's look at how your life works, how you approach this pain. And that's going to help. He's going to help you that way much more than my opiate medication, which is just going to addict you and cost you money. Any other questions? Well, I want to thank you all for coming. Hope you've learned something. I hope you realize that it's a lot more complicated than you realize. But what I think it does is puts the onus back on you. And that's the key thing. You can't be passive. You've got to take an active role in your own health. And yes, if you take an active role, have some direction. That's what this can be, is direction. Am I right?
Yep.
They're going to give you direction. You've got to do it. I know. I've had 3 strokes. I've got sarcopenia like you can't believe. I'm wasting away, but I still keep active because if I don't, I might as well just haul in the corner and wait for the undertaker to come and get me.
I do want to add one thing. It is more complicated, but that's a good thing because what you've been doing before didn't work. So now you've got other things to think about, other things to try. And I think that complication, if you don't understand that it exists, leads you to more hopelessness. But the complication that gives you an opportunity to explore and try some things and get some control, that leads to a sense of hope and possibility. So hopefully you've got that.
That's the key. Possibility. You don't have to give up. Thank you very much, sir.
You're
We
welcome.
have one more tape out there somewhere, I think. There should